Sciatic nerve block can be performed using peripheral nerve stimulator guidance with appropriate block needle length based on the depth of the nerve. Ultrasound guidance using either linear or curvilinear probe, again depending on the depth and location. In deep and difficult approaches, dual technique is preferred, especially when visualization or stimulation is suboptimal to improve accuracy and safety. The choice and the concentration of local anesthetic depend on the purpose of the block. For analgesia, lower concentration may suffice, and for anesthesia, higher concentration is required. The recommended volume of local anesthetic is usually between 15 to 20 ml. So what are the indications of the sciatic nerve block? The sciatic nerve block can be involved for the procedures or surgeries involving the pelvis, posterior thigh, leg or foot and ankle. It can also be used for joint surgeries involving the hip joint, knee joint or the ankle joint. The absolute contraindication include local infection at the site, sepsis, allergy to local anesthetics or patient refusal, whereas relative contraindications include coagulopathy or patients on anticoagulants or patient with a pre-existing neuropathy. For successful block, knowledge of key landmark is essential. Important bony landmarks include posterior superior iliac spine, iliac crest, greater trochanter, and ischial tuberosity, as well as the sacral hiatus. This helps in needle positioning and ultrasound probe placement at the most likely location of the nerve. Blood vessels are another important sonoanatomical landmarks, which includes superior gluteal artery accompanying the superior gluteal nerve above the piriformis, inferior gluteal artery accompanying the inferior gluteal nerve below the piriformis, internal pudendal artery which travels with the pudendal nerve through the lesser sciatic foramina, and accompanying veins that follows arterial pattern and may increase bleeding risk. Recognizing these vascular landmarks helps to avoid complication and aid in needle direction planning. It is also essential to understand the muscular landmark which lies above and below the sciatic nerve and which helps in identifying the nerve due to its anisotropic property under the ultrasound. Identifying the accompanying nerves along with the sciatic nerve also helps determine the extent of the analgesic coverage for your block. So how do we remember many described approaches to the sciatic nerve? Simple rule, just follow the nerve from its origin to its termination. The sciatic nerve can be targeted at multiple levels during its pelvic course, in the gluteal region, and in the posterior thigh. In the pelvic region, it is targeted via parasacral approach, which is the most proximal approach to the sciatic nerve. Since this level allows access to all branches of the sacral plexus, it is also referred to as sacral plexus block. Gluteal approaches include transgluteal, subgluteal, and infragluteal, whereas thigh approaches include subtrochanteric, mid-thigh approaches, and popliteal sciatic approaches. The terms anterior, posterior, and lateral approaches are based on needle entry directions. In posterior approach, the needle goes from posterior to anterior. In lateral approach, needle goes from lateral to medial, and in anterior approach, the needle goes from anterior to posterior.